So on behalf of the Regional Emerging Special Pathogens Treatment Center here at Mass General Hospital in Boston, I'm pleased to welcome you to our talk today, the Ugandan response to the 2022 Ebola outbreak, perspectives and lessons learned. My name is Erica Shinoy. I'm the medical director of our center and an infectious diseases physician. We'll go to the next slide. Here are some housekeeping about the talk today. So the learning objectives are listed here. There's also information about accreditation and the sort of credit that you can get for attending this course. Again, we'll post the SMS code in the chat for those who didn't have a chance to write it down. We'll go to the next slide. I want to acknowledge that this webinar is presented by the Regional Emerging Special Pathogens Treatment Center here at MGH in collaboration with the Region 1 Disaster Health Response System. Both of these programs are funded by the Administration for Strategic Preparedness and Response, that's called ASPR, within the U.S. Department of Health and Human Services. Next slide. This is the disclosure slide, which you can read at your leisure. I just want to highlight that the speakers have no affiliation or financial interests or relationships to disclose. And with that, I will turn this over, I think, to Dr. Olds. Yeah.
Thank you so much. Hello and welcome everyone to our session today. My name is Peter Olds. I'm an internist in the Hospital Medicine Division of Massachusetts General Hospital and also the Assistant Director of Uganda Programs at the MGH Center for Global Health. It is my great pleasure to introduce our two very distinguished guests today. First is Dr. Rose Muhindo, who's a senior lecturer at the Mbarara University of Science and Technology in Mbarara, Uganda. She's an internist and was the previous head of the Department of Medicine at the Mbarara Regional Referral Hospital. She was the lead physician of the Viral Hemorrhagic Fever Task Force at the hospital and in the region in 2018, and is the current lead physician of the Special Pathogens Unit at the hospital in the region, which has been a major part of the COVID-19 response there, in addition to ongoing preparations and response to other outbreaks. She also has extensive teaching background in research in infectious disease. Our second speaker is Dr. John Sentamu. He is Uganda Ministry of Health and World Health Organization Ebola viral disease case management expert. He's actively participated in numerous previous Ebola responses, including previous ones in Uganda and also in Sierra Leone. He was at the center of the response of the current outbreak, most recent outbreak in Uganda, as he'll explain more. In Sierra Leone, he headed the 100-bed Ebola treatment unit that was run by the African Union, which was deemed a model Ebola treatment unit for West Africa with some of the best outcomes across the region. He also does Ebola viral disease training for the Ugandan Ministry of Health and World Health Organization, and also has extensive research background in infectious disease and is currently the non-communicable disease head for Partners in Health in Liberia. So without further ado, I'll turn it over to our experts today, starting with Dr. Rose Muhindo. Thank you so much, everyone, for coming.
Thank you very much, Peter, for the warm invitation and the welcome, and thank you very much. Privileged to be part of this meeting this morning. Yes, so I'm going to be giving us a brief overview about the Ebola virus, and most of the slides are just reminder slides. I have a disclosure to make that these slides are actually not mine. They are slides that have been prepared by the Ministry of Health in Uganda in collaboration with the content from the World Health Organization, and these are slides that are being used for training purposes across the country. Next slide, please. So as a reminder, so we know that viral hemorrhagic fevers basically have four classifications, and particularly for this talk, we're going to be looking at Ebola virus, which is from the Filoviridae class. And this slide is showing us that the things that, or the viral hemorrhagic fevers that have been experienced in Uganda are the ones shaded in blue. And that's mainly the Crimean Congo, Rift Valley fever, which fall under the Bunya-Viridae class. Then Ebola and Marburg, we also had outbreaks of those, as we know, and that's under the Filoviridae. And then yellow fever virus has also been experienced. Just to also say that we have had at least up to 2 outbreaks of Rift Valley fever, 2018 and 2022, but also this year we've had just a few sporadic cases. Next slide, please. Yeah, so viral hemorrhagic fevers are severe multi-systemic febrile illnesses that are caused by RNA viruses, and these are very highly transmissible, particularly through contact with body fluids from infected persons and also through vectors. And this can be seen in cases of yellow fever and dengue. For Ebola and Marburg, it's mostly through infected body fluids together with Crimean Congo virus. Next slide, please. Yes, so how do we actually get the virus? So for Ebola and Marburg, and so most of these will be through a single pass from animal to human. So we know that there are bats that are the natural reservoirs for this virus, for Ebola virus. So contact to the humans, either through bites or the excreta of these fruit bats specifically, or other primates like chimpanzees, monkeys, all these things need to get into contact, or humans need to get into contact with these, then the virus will get into the body. As it does that, then it will amplify and then lead to transmissions in the Ebola outbreak. Next slide, please. So this slide is showing us the distinct Ebola species and the associated mortalities that have happened on the continent of Africa. And as you will notice that, yes, we have, so the family from which Ebola comes is the Claviviridae, and the genus is the Ebola one. And then under the Ebola genus, there are 5 species that have been identified. So that is Zaire, Sudan, Bundibujo, Thai, and Reston. In this, what has happened across the continent of Africa, we see that there have been various outbreaks in several parts, but mostly in West Africa, in East Africa, and also in Central. And then a few cases have been reported in Southern Africa. We see particularly within East Africa, in Uganda particularly, we've mostly had the Sudan species of the virus. So the different case fatality rates also come up on the next slide, please. So in Uganda, the outbreaks that we have experienced, so the big one that we had was in 2000, and that was in the northern part of the country, a place called Hulu. And at that time, the case fatality rate was about 53%. Then we later had the Bundibujo virus as well, the Bundibujo outbreak. The strain that was responsible was the Bundibujo strain. Luero, which is a different part of the country, has also had 2 outbreaks, one in 2012, another in 2011, and also in Chivale, and recently in Bende. So the total number of cases that were confirmed were about 142, with a case fatality rate of about 38.7. You will notice that the strains that have been responsible for these outbreaks, majority have been the Sudan strain. Next slide, please. So just a little about the virus. I'm sure we don't want to go too much into the detail of this, but it's generally a non-segmented filamentous lipid enveloped RNA virus. And without going into the detail of the structure, but what we know about this virus is that it can easily be destroyed by soap and water, and then chlorine and environment. Now, this is very important, especially from the infection prevention and control side of things. Next slide, please. With regards to the transmission, the incubation period is anywhere between 2 and 21 days. Generally speaking, patients are not contagious until they are symptomatic. Now, when they become symptomatic, the viral load goes up. And it's at this point that they will be very infectious through any of the body fluids that we can think about: blood, vomiters, excreta, and so on and so forth. There are certain high-risk groups also that have been identified. This includes women, because these are mostly the caregivers of patients who take care of patients. It has also been confirmed that the virus can actually persist in semen for up to about 12 months. And this is also very important for us to note, especially when we're discharging survivors of the virus. It can also persist in breast milk, and This also is very important when it comes to giving the right information to pregnant women and also breastfeeding moms. The dead bodies of Ebola virus are actually quite infectious, and many people are supposed, so that's what actually calls for the safe and dignified burial teams that are advocated for. We also are aware that because it persists on contaminated items like linen and needles, it is important that these are actually destroyed safely and so that we reduce the spread of infection. Next slide, please. So some studies or some work has been done to try and identify or to help people actually know when they should think about possible viral hemorrhagic fever. And the risk factors here that, or the epidemiological characteristics of this disease is that if at any one time there's a clustering of patients with unexplained fevers, it's with unexplained etiology, we should actually raise our index of suspicion. Unexplained deaths also in both humans and non-human primates should also raise the index of suspicion. Certainly, if somebody has had contact with an infected animal, bushmeat, patients who have also, people who have also had contact with blood from infected people, whether they are dead or alive, this should actually increase our index of suspicion. Certain risk groups have been identified as being more at risk. Healthcare workers, that's self-explanatory by virtue of the work that we do. There's a big risk as you get in touch with the patients. Family members of households where there could be an infected person, caretakers, caregivers, and then also traditional healers. Now, in Africa, it's not uncommon for people to think about witchcraft as a cause of, for example, unexplained deaths, unexplained fevers. So most people would normally first go down the cultural route or the traditional route. So all these people are obviously going to be at risk, and also the people who are participating in traditional burial rituals also know that in some parts of Africa, there are certain cultural practices that happen in different tribes, especially when somebody dies. And this is obviously going to increase the risk of spread of infection. Next slide, please. Now, this data came out of one of the outbreaks that we're trying to look at what are some of the things that can actually amplify an epidemic. Now, as we know that case zero is mostly difficult to identify. When people have a very low index of suspicion, that could actually lead to the amplification of the virus. As healthcare workers, the non-adherence to the universal precautions, that will definitely increase the risk. We have certain parts of some healthcare facilities that actually do not have the standard operating procedures that could also lead to an amplification of an outbreak. Shortage of supplies, that's very common in our setting. Some people don't even have like the regular necessary personal protective equipment that is needed. High mobility of patients is also going to increase the risk of spread or amplification of the outbreak. And then areas that have lots of human activity, including mining, deforestation, maybe hunting, all these things are also going to amplify the risk. And then also cultural practices, and that's particularly for the burial practices that might happen in certain cultures. Next slide, please. Yes, so we say that healthcare workers are actually at risk, and that does not surprise anyone. This slide is depicting the late Dr. Matthew Rupia. He will continue to rest in peace. This is one of the doctors that we lost in the 2000 outbreak. And in that particular outbreak, there were up to 13 healthcare worker deaths. In this current outbreak that we just had recently, that was in Bende, there were 19 healthcare worker infections with up to 7 deaths. So we know that because the risk of infection is very high, there's a need to actually continuously remind healthcare workers of the standard operating procedures and the different SOPs that are required, but most especially to increase the availability of PPE this would definitely go a long way in minimizing healthcare worker infections, but also to encouraging healthcare workers to adhere to these universal precautions. Next slide, please. So what happens when the virus gets into the body? The virus needs to get access to the body through either broken skin or the mucosa. After you have this virus in the body, it's going to replicate, disseminate. And once this replication takes place and the dissemination, the hallmark is in offsetting a pro-inflammatory state. Lots of cytokines are going to be released. And these mostly will cause vascular irritability, leakage, and shock. So that means there's going to be widespread tissue damage, including the liver, the kidneys, and name it. Whatever organs that you can think of, febrile illness. So with all this, there's going to be lots of necrosis and tissue damage. Next slide, please. Yes, so this slide is literally meant to show us what happens in the immune response. So remember, we said the incubation period is about 2 to 21 days. Now, looking at this graph, we see, let's imagine that somebody has been infected, maybe day 0, maybe somewhere around day 7. So in between there, they're actually in their incubation period. During that time, the patient is asymptomatic. When the viral load starts to increase, this patient is going to mount a fever, and it is at this time that they are going to become symptomatic. It is at this time that the diagnosis can actually be made. At the same time, the host's immune response will start to also come in maybe about day 10 or so. And in here, you have the IgG and IgM antibodies beginning to build up in the patient. Next slide, please. Yeah, so how do patients with Ebola virus present? Now, the clinical features, to be honest with you, as we probably know, are rather non-specific and could look like any other infectious disease that you can think of. Earlier on, patients present with fever. That seems to be the hallmark, and majority of patients will have a fever. You could have a headache, muscle aches. Later on in the disease, patients will have quite a number of illnesses. Now, because of the way they are presenting, it actually increases the differential diagnosis, which could include malaria, typhoid, rickettsia, and so on. So, next slide. So in the clinical laboratory features, you realize that and the clinical features, we didn't really mention hemorrhage as a big thing. So this is what has been demonstrated. In less than a third of patients with Ebola will there be hemorrhage. So the problem that we have is because most of us know it as a viral hemorrhagic fever, the absence of bleeding actually reduces the index of suspicion, and this could actually lead to amplification of the spread if that was a patient that we are not aware of. But in terms of the other laboratory parameters that can be done, patients on a full blood count will mostly have thrombocytopenia. If they already have organ damage, they will have different metabolic features of acute kidney injury and liver injury. Next slide, please. The virus, how can it be detected in the laboratory? So PCR test is what is commonly done, and here it's actually more sensitive and quite rapid and can help in detecting the antigen, the actual genetic fragments of the virus. ELISA tests can also be done. Virus isolation can be done by high-level labs, which are available in our setting, but the virus can also be detected on immunohistochemistry and histopathology, that is from tissues that have been taken from infected people or dead animals. Next slide, please. Yes, so in summary, as an overview, viral hemorrhagic fevers are highly contagious. They're zoonotic, as we've seen that most of them are going to come from contact with animals. Human-to-human transmission is there for Ebola, Marburg, and the others, except for Rift Valley fever. So just a bit of history, the virus was actually discovered in 1976, and there were two simultaneous outbreaks that happened. One was in a place called Nzara in South Sudan, and then another one was in Yambuku in DRC, and particularly that outbreak in Yambuku happened along the Ebola river. That is how it got its name. Since then, there have been multiple outbreaks in different parts of the continent. Uganda has been one of those countries that has been affected. Once infected, patients will have a multisystem febrile illness. Diagnosis is mainly by PCR, and treatment is mostly supportive, although a few treatments have been approved by the FDA fairly recently. Thank you very much. I hope that was just a brief overview of what we'll be discussing today. Thank you so much, Peter. Over to you.
Thank you, Dr. Rose. I will now turn it over to Dr. Sentamu.
Thanks so much, Peter, and thanks everybody for joining in. I'll now move straight to the Ugandan Ebola virus disease response and what we learned as lessons from the outbreak. Next slide. The 2022 Ebola outbreak in Uganda was declared on the 20th of September of last year, and this followed isolation of the Sudan Ebola virus from a suspected case at the Uganda Virus Research Institute. The index case is believed to have been a 24-year-old male from Madudu sub-county in Mubende district. Now, this case had been admitted to Mubende Regional Referral Hospital on the 17th of September, where he later died on the 19th of September. Before then, he had sought treatment at two private clinics within the district. Even before this case, there were a number of several community and health facility related deaths that had been noted to have occurred dating back to early August of last year, meaning at that time, there was a probable undetected ongoing community transmission within the country. Retrospective investigations into this undetected probable community transmission established two transmission chains from Madudu and Kiluma sub-counties in Mubende, and these two transmission chains were later on found to have been linked to the index case. As the outbreak continued, there were other transmission chains, however, that remained unlinked to this first case. Next slide. Next slide, please. Peter, can we move to the next?
Dr. Sentamu, I think I've moved. I'm on the background continued timeline. May have lost connection here. Oops, sorry. We'll see if we can get a hold of Dr. John here. Thank you all for your patience here.
Sorry, I hope you can hear me now.
Yes, we can. Thank you so much.
Oh, so sorry, I had issues with the network. So from Mubende, like I said, the outbreak later spread to 5 other districts, and that included the districts of Kampala, which is a highly populated area. So here we see that the death occurred before identification of the index case, and they are believed to have been EVD related. We see death A1, which occurred at Mubende Regional Referral Hospital, death A2, which occurred in a private facility, A3, which occurred in the community, but came from the same village as A1, A4 occurred at Mubende Regional Referral Hospital, A5 occurred at a private clinic, A6 was an enrolled nurse death that occurred in a private clinic where A2 died also. And we can see that a total of 6 probable EVD cases occurred before the index case was identified. Next slide. So following declaration of the outbreak, the Minister of Health, WHO, and partners set up a robust response plan, and the Ebola response mechanism was activated in all the affected districts. The country was categorized into very high and moderate risk districts, and Mubende and Kasanda, including Kampala, were among the very high districts. Stringent health and social measures were instituted, including a lockdown of Mubende and Kasanda, which was on the 15th of October 2022. And the outbreak lasted up to 112 days, and it was declared closed on the 11th of January 2023. Its case load and case fatality did not surpass the largest outbreak that has been mentioned by Dr. Rose of 2000, which killed 224 persons in Gulu. Next slide. So how was the response organized and what was done? The National Response Plan was organized into various pillars, including the coordination, surveillance, lab, case management, community engagement, risk communication, continuity of essential health services, strategic information research and innovation, and logistics. Next slide. There was a strategic management committee, the National Task Force, Incident Management Team, Emergency Operations Center, District Task Force, Partners Coordination Forum, and Resource Mobilization Forum. Health development partners, including ambassadors, UN agencies, were all coordinated into the response. There were weekly high-level field visits by the National Task Force to monitor the response and to stand by the healthcare workers at the front line. The WHO opened 2 coordination offices, one in Mubende and the other one in Kasanda. And an ecological study team was deployed to determine the environmental risk factors, and the public sector was also engaged. Next slide. Here we see the WHO Regional Director and Minister of Health in one of the high-level visits addressing healthcare workers at one of the ETU. We see the National Task Force meeting sitting at the district headquarters in Mubende, the district task force in one of their sessions, and we also see the WHO country representative plus the WHO regional director, again in the field inspecting a tube isolation unit at one of the ETUs. Next slide. Under surveillance, systems were set up for alert management, case investigation, quarantine, point of care, community-based, and mortality surveillance. There were 30 epidemiologists who were deployed by WHO. Village health teams and healthcare workers were trained, and daily situation reports and disease outbreak news were published. Open data kits were rolled out, protocols and job aids were developed, and over 200 surveillance officers were trained. Next slide. The lab was designated as a separate pillar responsible for sample collection, transportation and testing, and result transmission. 2 mobile labs were deployed, and sample genomic sequencing was initiated at the Uganda Virus Research Institute. Point of care investigations were also provided in the ETU. Next slide. Samples were not only being collected from suspected cases, but also from all dead bodies within the high-risk districts. This is an example of the lab result for samples that were collected from dead bodies between the 17th of December and 23rd December. We see that majority of the samples were coming from the very high-risk districts of Mubende and Kasanda. Next slide. As earlier mentioned, I was part of the case management response team that was based in the ETU in Mubende and taking care of cases from both Mubende and Kasanda. Under case management, we set up 5 Ebola treatment units, and we basically had 5 sub-pillars under the case management. We had the clinical sub-pillar, the mental health psychosocial, the emergency medical services, IPC, and the SDB, safe and dignified burial. We trained over 290 healthcare workers in case management, and we also trained 2 safe and dignified burial teams and developed guidelines and SOPs for the survivors program. Next slide. Here we see a pictorial of the ETUs that we use. These were main latent ETUs that were set up with the support of MSF. Next slide. The ETUs had different bed capacity catering for suspected and confirmed cases as shown in the slide. And in Mubende at the Kaweri ETU here represented by ETU2, out of the 42 bed capacity, we had 9 beds for ICU and 1 tube isolation unit. Mulago and Kiludu were designed as isolation facilities catering for only suspected cases. Next slide. EVD formal case management training was mandatory before deployment to the ETU, and this is usually a 5-day training in both theory and practical that is based on the WHO case management training module. Next slide. Also, before deployment to the safe and dignified burial teams, formal safe and dignified burial trainings was mandatory. Again, this was based on the WHO training modules. Here we see healthcare workers taking part in the practical sessions for the case management, safe and dignified burial teams. Next slide. So what were the statistics like at the end of the outbreak? So a total of 9 districts were affected. The cumulative number of confirmed cases were 142, including 19 healthcare worker infections. There were 55 deaths, including 07 healthcare worker deaths, and the case fatality rate was 39% overall. Next slide. This slide shows the outbreak epi curve. There were 3 peaks. First peak was at the beginning of the outbreak in the 2 sub-counties of Kirwani and Madudu. We see a second peak in October that followed the death of case 83. Case 83 had died and safe and dignified burial was performed. The community exhumed the body and conducted burial rituals. This led to 31 contacts and many confirmed cases, and that's how we got that peak that we actually see that happened towards the end of October. It was that peak that again spilled over to Kasanda, where we saw the highest peak in Kasanda, which was also linked to case 83, and that was the same cluster. Next slide. The most affected age group was 20 to 29 years, followed by 30 to 39 years, and more males, 61%, compared to females, 39% were affected. Next slide. The commonest presenting complaints among adults on admission were fever and general body weakness. We see that majority of the patients presented with non-specific symptoms and none presented with bleeding. Next slide. Among the children, the commonest presenting complaints were diarrhea and fever. It's only 2 out of 18 confirmed children that presented with bleeding on admission. Next slide. The average length of stay in hospital was 5 days. Mortality was highest among the children 0 to 9 years and the adults 50 to 59 years. We see a case fatality rate of 72% and 75% respectively in those two age groups. You can see that between 0 to 9 years, the case fatality rate was 72, and 50 to 59 years, the case fatality rate was 75. Next slide. The factors associated with mortality were late presentation to hospital, advanced age, comorbidities, development of acute kidney injury, and acute respiratory distress syndrome. Being a child was associated with a 50% mortality rate, as 9 out of the 18 confirmed children that had EVD died. Next slide. Majority of the confirmed cases were from suspected cases, and there were a total of 1,386 suspected cases by around 18th December who had been admitted to the ETU, meaning that there was a very high-level surveillance system that was picking all suspected cases from the community. Next slide. Looking at the ETUs and the activities therein, the ETUs had a very well-organized daily and weekly activity schedule ranging from routine clinical care to environmental cleaning and disinfection and psychosocial support. On this slide, we see patients being received at the ETU and donning in preparation for clinical care taking place at the ETUs. Next slide. Here we see clinical morning meetings at the green zone and the red zone. There were also weekly coordination meetings at the ETU. Next slide. So you can see that among the activities, apart from the clinical meetings, there were weekly coordination meetings that were taking place. On the left upper part of this slide, we see the clear visibility ETU model, which was deployed in one of the ETU wards. And again, you can see that in that model, you can see that you can have a ward round that takes place both in the high-risk red zone and in the green zone. The healthcare workers in PPE are in the red zone, and the healthcare worker in a scrub suit is in the green zone. Next slide, please. The survivors program, which is ongoing, entailed discharge from the ETU with a package that was consisting of daily use items. These include things like mattresses, food items. It also entailed discharge after psychosocial counseling, following up in the survivors clinic, and return to the clinic in the ETU for delivery for those pregnant survivors who were discharged while they were pregnant. This program also entails ongoing semen testing for male survivors, protected sex for at least 1 year, and clinic follow-up for care based on the survivors guideline. So this slide shows one of the discharge ceremonies for the last survivors from the ETU on 30th November 2022. Next slide. Survivors usually have a number of symptoms post-recovery, as shown on this slide, and most of these symptoms are usually non-specific symptoms. But what I need to highlight, next slide, what I need to highlight is that even after discharge from the ETU, the virus has been shown to persist in various body compartments and may lead to community transmission if no measures are taken. This slide shows persistence of EVD in various body compartments. We will specifically look at serum and breast milk. The red bar represents the day of the first negative blood PCR, and that should be the day of discharge from the ETU. Once somebody has a negative PCR based on blood, they are discharged. However, we see that for semen, we see that after discharge, semen culture will remain positive up to around day 100. That is the blue graph, and the semen PCR or culture may also continue to remain positive. And that's the rationale why we usually ask the survivors to continue having the protected sex even after discharge. For breast milk, the positive PCR on breast milk continues after the patient has had a negative blood PCR. That means that if you had a lactating mother who suffered from EVD, they may be discharged from the ETU based on a negative blood PCR, and they continue to have positive breast milk PCR, meaning that you encourage them not to breastfeed and use formula feeds. Next slide. So following discharge from the ETU, we noted that a total of 14 male survivors representing 25% continued to have scrotal pain and swelling. And we really thought that this may be related to the persistence of the virus in the semen. Next slide. So that's what was done. And these in general were the strategies that helped us to control the outbreak. One, the early identification of suspected cases, evacuating them timely to the isolation units, the linkage to other essential healthcare services for suspected cases who were brought in and tested negative on PCR, then the removal of the confirmed cases from the communities and then isolating them, providing quarantine for the contacts to the confirmed cases that helped to break the chain of transmission. And then there was this robust alert system with alert verification and evacuation of cases from the community to the ETUs. The safe and dignified burial for all death in the ETUs, health facilities, and the communities was the other strategy which really helped to break the chain of transmission. Next slide. So what were the lessons learned? First and foremost, in this outbreak, we noted that malaria and EVD comorbidity was common. It was about 30 to 50% on daily malaria RDT. Majority of EVD confirmed patients presented with acute respiratory distress syndrome before death. Point of care tests markedly improved care. Premature labor, intrauterine and fetal death was seen among pregnant confirmed cases. The ETU design with improved visibility was as was the case for the ICU at Kaweri, markedly improved care. We noted vertical transmission of EVD from mother to fetus in one of the pregnant survivors, and that led to a macerated stillbirth with a positive PCR on the baby that was taken. Then we also noted persistent EVDR PCR positivity in breast milk. It was noted among one female breastfeeding survivor. And then, as alluded earlier, scrotal pain was observed among 25% of female survivors. Next slide. Sexual transmission of EVD from one male survivor to a female counterpart was also noted in this outbreak. And we also noted that none of the high-risk healthcare workers who were contacts to a confirmed healthcare worker developed EVD. There was one EVD infection of an healthcare worker who was working within the ETU, but later on we noted that the source was linked to activities outside the ETU. Then the prior experience gained from the care of EVD confirmed cases in West Africa and other previous outbreaks in Uganda was key in supporting this response. Next slide. Co-location of the ETU in proximity to the regional referral hospital provided easy linkage to care for the suspected cases. And we had no routine COVID-19 testing for confirmed cases. We really noted that as was a gap. It was a very big gap. The availability of the Piccolo machine markedly improved the care, and the training of specialists, especially the obstetrician, gynecologist, pediatrician, improved the ETU care for confirmed pregnant mothers and children. And we also noted that it's usually very important to have a specified designated ETU data clerk or statistician. Next slide. So we would like to recommend for future outbreaks that the ETU design should have clear visibility. Every ETU should be designed in such a way to have an ETU delivery area. Obstetrician, anesthetist, pediatrician should always be part of the team. Pediatric drug formulation and oxygen delivery system should always be prepared. The case management trainings should be updated now to include the newer therapeutics that are coming up, such as the MBP 134 immunoglobulins. And then we also note that usually it's important to have a rota for responders. We think that it would be important for future outbreaks to deploy point of care ultrasound and echo in the red zone, and also to deploy blood transfusion services in the green zone within the ETU to make it easier for blood transfusion. The EVD survivors program should be able to deploy full-time specialists in those specific areas, such as ophthalmologists, mental health specialists, physicians. And the COVID-19 testing should be part of the case management protocols. Also, the data systems in the ETU should always have specific designated attention. EVD vaccination strategy, yes, now there is a big talk that vaccination should not wait for outbreaks. And again, that is something that is being discussed across the globe. Thank you, and over to you, Peter.
Great, thank you so much, Dr. Sentamu and Dr. Muhindu. Really fantastic lecture and lots of wonderful information there. I think now we'll start our questions. If people have questions, please put them in the Q&A, or we'll be monitoring the chat as well. I can certainly start things off. I think one question quickly for Dr. Sentamu, in terms of the clinical treatments available in the ETUs, what was sort of the range? And it was interesting to hear about the ICU as well, sort of the range of care between the from regular ETU wards to the ICU ward.
Yeah, thank you so much. We have gone a long way in terms of optimizing the care. Initially, we never used to give blood transfusion. Now we give blood transfusion. Initially, we never used to give oxygen therapy. Now we give oxygen therapy. In our response, we tried out the MBP 134. Again, those are still medications that are still on trial. But by and large, supportive management, optimizing the care, basically is what is available with the symptomatic treatment, and making sure that for whichever complications the patients they receive the appropriate care for that. Over to you. Great,
thank you. See, I can keep asking questions too. Let's see. We have a question from Erica Shinoy. Are they participating in research studies in the ETUs in the sense that they are using investigational therapies? It sounds like a little bit yes, but I'll let Dr. John answer.
Yes, response to outbreaks is usually a very good opportunity to try some of the therapies that are available. But by and large, in this particular response, there were no structured researches that were ongoing during the response. The monoclonal antibodies that were brought on board again were being used to try and see if they could do help based on the literature that is available, that they were found to be helpful. In terms of the research agenda, it is mainly the survivors program where a lot of structured research is expected to be ongoing, including the semen testing, breast milk testing, to try and see whether the findings would really tally to what is already known. Over to you, Peter.
Thank you. Here we have a question from John Barino. While transmission via semen appears to be low, are surviving males provided condoms? Is there compliance with use of condoms?
Yes, that's quite of a challenge, because monitoring whether the survivors would use the condoms or not would be quite challenging. But true, it's part of the discharge package for male survivors. As they undergo the psychosocial counseling, they are provided with a package of condoms and they are requested to use them. And that information is continuously reinforced as the survivors are visited by the teams. Of course, case by case, you may hear survivors who come in and they confide that it's very, very challenging to consistently use them. Also, the fact that we had an infection from a male survivor to a partner shows that there's still a lot that we need to do in that area. But formally, yes, that is the arrangement, and that's how it's meant to be. Over to you.
Great. Another question here is about how long are shifts for the clinicians working in the ETUs?
Well, that's a good question, Peter. You know very well that fatigue and overwork may be one of the factors that may lead to risk of exposure to the EVD virus. So the clinicians basically the senior clinicians were doing, there are 3 shifts, and for every shift during the day, you would have 1 senior clinician. So it would be 1 shift every day for every clinician. And you would expect that in a week, there is supposed to be a day off for the clinicians where they are expected to be resting and not coming to the treatment unit.
Great, thank you. Dr. Stephen Asimwe asks, was lockdown necessary or effective in control? Was there evidence behind it? And then in general, how do you view lockdowns? I think question for both presenters.
Yes, for the high-risk districts in Mubende and Kassanda that underwent lockdown, again, these are decisions that are usually taken at very high level. They are usually very well thought through. If you look at the epi curve, you definitely see that at that particular time when we had the 3rd peak and the lockdown was instituted, the cases came down. So the lockdown is on record to have helped in this particular response. And again, like I'm saying, there are quite a number of perspectives to a lockdown, different perspectives. But on the medical side, the health side, yes, the lockdown in the high-risk districts helped in this particular response.
Great. Another question, I think for both presenters. Do your teams have any significant goals around Ebola response for the next 5 to 10 years?
If I may take that up for the next 5 years, yes, there is usually a very clear roadmap for response to Ebola. Right from the response, then there comes the post-response phase with very clear timelines, including things like training, including things like working on the lessons learned, including things like strengthening the systems. Yes, for 5 years, usually, even when the plan may not be specific for a whole 5 years, but they are usually phased programs, including the exit strategy from the response. So there is usually a plan after the response, just in preparation for any other outbreak that may come.
Great.
If I can also add, Peter, so so this time, obviously in Southwestern Uganda, we were not part of the response. But what has happened now is that even if we didn't have any cases, there's been lots of active training going on, because we realize that many times when there's an outbreak, we spend more time trying to look for teams and create the team. So what has happened this time around, together with some implementing partners, there's been ongoing creation of different districts and district rapid response teams. So people have been identified and have been trained. And the plan is to continue at least having CMEs even when there is no outbreak, so that when the real thing comes back, people will be more competent and not afraid to actually be part of the response. Thank you.
Great. And Dr. Rose, thank you. And just to follow up on that a little bit about sort of your hospitals and your approach, your team's approach to screening. There's a question here about the high frequency of co-infection of malaria and EBD being worrisome, and that it might be a reassuring thing if someone tests positive for malaria if they're coming in with fevers and malaise. And just sort of wondering sort of how those sort of cases are thought through, and how your team thinks through sort of during an epidemic, but also in sort of the times between.
Thank you. Let me try to answer. Maybe Dr. Sentamu can answer the rest. So particularly from Mbarara, one challenge that we have, because we have one central lab. So when we have outbreaks like Ebola, it's very difficult to use the same lab to test, to do any other, maybe like chemistries and things like that. But one thing we have for sure is at least some point of care tests, and that's obviously the malaria RDHRS. So one of the screening things that is actually used is when patients present with the symptoms that they will present with, at least everyone is supposed to have a malaria test. And that has helped us not only, but also for Rift Valley fever and Marburg and CCF that we have actually handled. So the malaria test is one of the mandatory things that at least our patients can have. And this is just because it's a point of care test. The other chemistry tests we are not able to do, unfortunately, because we have only one lab, as I have said. Dr. Sentamu, do you want to add?
Yeah, maybe I may say that in this particular response, the response happened at a time where we had the rainy seasons, and also the children were being affected. They were coming down with lots of severe malaria. So in that particular case, the Ministry of Health Malaria Control Program took very quick notice of that, and they came up with community programs where they came to the communities, increased the awareness, the sensitization in those particular districts, and they also rolled out provision of anti-malarials door-to-door for the most vulnerable high-risk communities. Yes, so it is something that usually the ministry would pick up quite easily.
Great, thank you. Well, unfortunately, I think we're at 10 o'clock here, Eastern Standard Time. I really want to first thank our presenters, Dr. Muhindu and Dr. Sentamu. Thank you guys so much for all your expertise and all for the amazing work that you both do every day. Excited for the future, and I want to thank everyone for coming, and really thank you for the speaker series, so thank you everyone. Have a wonderful rest of the day. Take care.